Welcome to Second Opinion. Clinical investigators provide perspectives on the role of AKT inhibition in the management of prostate cancer. This is medical oncologist Dr. Neil Love. On February 27th at the 2026 GU Cancer Symposium in San Francisco, we held a CME meeting moderated by Dr. Elisabeth Heath from the Mayo Clinic in Rochester, Minnesota, with faculty members Dr. Karim Fizazi from the Center Oscar Lambret in Lille, France, and Dr. Dan George from the Duke Cancer Institute in Durham, North Carolina. Included in the meeting were a series of pre-recorded video case presentations with Dr. Neeraj Agarwal from the Huntsman Cancer Institute in Salt Lake City, Utah, and Dr. Rana R McKay from the Moores Cancer Center in San Diego, California, who met with me prior to the meeting. These cases were discussed by the faculty panel, beginning with some questions from Dr. Agarwal.
Now I have questions for Dr. Karim Fizazi. Looking back at iPotential 150 trial, what was the key signal that convinced the field that AKT inhibition is biologically meaningful? What were the main reasons that ipatasertib program did not move forward despite positive signals in subsets of these patients? How do you think about the pharmacologic differences between ipatasertib and capivasertib? Should we now be routinely testing PTEN at the time of MHSPC diagnosis to identify candidates with high degree of PTEN loss? How would you prioritize triplet therapy with docetaxel versus triplet therapy with ARPI plus AKT inhibitor? Where do you see AKT inhibitor story going next? Earlier in the disease, combination strategies, or biomarker refinement? Beyond PTEN loss, are there other genomic signatures that may predict benefit to capivasertib?
Do you see yourself using capivasertib if it becomes available to treat prostate cancer?
If you look at 100% PTEN loss, the data are quite compelling. 22 months with ADT plus ARPI and 34 months with ADT plus ARPI plus capivasertib. That is an year added to our patients' lives without experiencing progression with a disease phenotype which is highly aggressive. And I think that's meaningful to me, yeah. I will use it, yeah. I think many of these patients experience disease progression in a rapid fashion that they are not able to maintain their performance status, or they are not able to maintain their desire or will to fight with cancer when they experience these severe symptoms with disease progression.
Wow, that's a lot of questions. So we have counted on Neeraj to deliver just that. Before we get to Neeraj's question, we do have a question from the audience. It's actually really insightful. What do you think in terms of the use of mTOR inhibitors in PTEN loss prostate cancer, Karim?
The past, we had several trials looking at mTOR inhibitors, either in selected populations or not, and the signal was weaker. Let's put it like this. It was not nothing. So some patients appear to benefit, but again in a weaker fashion. Mm-hmm. So this is why it was not pursued. At least for most of them. But I think some companies are still considering this.
Mm-hmm. Certainly a compound we're familiar with. Now, it's a tough question. Why did ipatasertib not move forward? Was there some major reason that this audience needs to know? Were there actual pharmacologic differences between the two agents? What do you think?
Yeah, I think, the EPA program was probably stopped in prostate cancer just because the magnitude of the benefit was smaller as compared to what I just showed in the randomized phase 2 trial. Mm-hmm. And it didn't really come with other benefit to patients. Overall survival was negative, and again, there was no time to deterioration, quality of life, time to pain deterioration, or time to SSEs. Endpoints that would convince you probably also the agencies to approve a drug and to use it in our practice. So this is why the pathocertib program failed, I think. Now, Neeraj was asking me what was the rationale from moving from EPAD to CAPI. I think I would say the consistency of the data that we saw in CRPC was a really good signal. Again, randomized phase 2 trial, 200 milligram dosing, 400 milligram dosing, same findings. PTEN loss benefit, no PTEN loss, no benefit. And then phase 3 trial, even if the magnitude of the benefit was smaller, the same trend, let's say, was supported. So with a different drug, potentially more active, there was clear rationale that we should try it also, and maybe earlier when the disease is easier, hopefully, to target. And this is why we chose metastatic hormone-sensitive disease.
Yeah. Well, and Dan, I might ask you, just in terms of if this actually was going to go to the clinic, how are you going to make a choice? We now have an abundance of riches of doublets and triplets and emerging other lutetium and PARPs. What do you think?
Yeah, I think that's going to be a really important question, but all of these are relative subsets. So when you're looking at sort of 25% of patients that have this 90% or greater loss of PTEN, the number of those patients that are going to have a BRCA mutation or MSI high probably going to be really low. So I don't think we're going to see like overlap of these targetable, actionable approaches too often. But there are other less biologically defined approaches like docetaxel chemotherapy or potentially radioligand therapy that could be applied to these populations. The truth is that we don't have prospective data with those approaches in this population. I think the most important thing to recognize is that this study, Capitello 281, defined a new biologic subpopulation of prostate cancer, PTEN deficiency. It has poor prognosis, and it has a different pattern of spread of complications, a higher, more symptomatic bone complication rate, a relatively low PSA at progression, and probably a higher rate of visceral progression. So it makes sense to me, based on the biology of AKT and this first step in developing differentiation towards neuroendocrine disease, to say that's what we really want to prohibit. Whatever side effects you show, the disease that's associated with this biology is worse. Yeah. So using a very specific targeted agent to disrupt that pathway early, before other alterations happen, is probably the best strategy we have. Other strategies like radioligands and chemotherapy we use throughout the natural history of this advanced metastatic disease, this is really targeted specifically for this population.
Well, Karim, we have a great audience question on this discordance that you mentioned in terms of PTEN and PSA. So the audience member wants to know, does that mean we should do imaging in a different way in spite of no rise in PSA? Thoughts?
Yeah, actually, this is a key question. I fully agree. We will do more effort in the trial to tease out how many patients actually progressed with 0 PSA rises versus how many of them progressed with some rises which did not reach the 25% threshold. And I think this is really key, because if ever most patients actually develop a rise in PSA, even modest, then perhaps we can keep using PSA only for those of us who do that, on top, of course, of clinical assessments in all the patients with metastatic hormone-sensitive disease and PTEN loss. Yeah. And knowing that we will need to react even if the PSA is just rising. Yeah. Now, if many patients actually experience a cancer progression with a 0 PSA rise, then you're very right. We will, or this person is very right. we will need to change all the pattern of surveillance and integrate, at least for these patients with PTEN loss, systematically some kinds of imaging. So hopefully we will be able to dig into those details this year. We have an agreement with a company to do so. And clinically, it's very important, I think.
Well, I think that's, again, from an audience, what am I doing Monday morning in my own clinic if this was available? Those are the questions that would make us know what to do next.
Absolutely.
Rana McKay is in another conversation with Dr. Love. Let's see what her questions are.
Dr. McKay's next case is a common vexing clinical scenario, a patient with hormone-sensitive metastatic disease with a suboptimal response to triplet therapy.
67-year-old gentleman presenting with de novo metastatic disease, had a PSA on routine screening. He wasn't having symptoms, PSA of 115. MRI shows that he's got a tumor in his prostate, 2.5 centimeter Pirates 5 tumor with extension out of the capsule, and also osseous metastases within the left femoral neck and the pelvic region. He had a biopsy, 4+3 cancer, 10 out of 14 cores were sampled, but he didn't have 8, 9, 10 disease. He did have a PTEN loss on NGS testing, ended up ultimately getting relugolix, darolutamide plus chemotherapy. And his PSA declined. He was at like 129, 67, 35, 2, and 1. And, he definitely was not in the group that hit that nadir PSA of 0.2 within 6 months. And even a year out or a year and a half out from him starting his therapy, his PSA was still 1.03. And so I think this kind of was a case around the question of radiographic progression on an RP despite a declining PSA. And I'm like worried about this guy. I'm scanning this guy every 3 to 4 months. I'm just worried of disease progression for him. This question comes up so many times with patients as well, that it's like, why are you waiting for me to progress? Like, why don't you just give me something to, prevent me from progressing? And I get it. I hear it. And a part of me does. It's like, I'm worried that he's going to progress and potentially progress in a bad way. And so what would you do? There is a trial called the triple switch study that's being conducted through the cooperative groups. And if they don't hit a PSA of less than 0.2, actually layering in docetaxel, he got triple therapy. So it's like, what are you going to escalate him with? This is a guy who, if I could add capivasertib right now, I would add it. I'm just worried about him.
Don't we all have those kinds of similar scenarios? I think in general, again, it comes back to you have a lot of options now for MHSPC. One of the questions is, if you were going to just think in terms of side effects and whatnot, Karim, is this a conversation with triplet instead of doublet versus, a new agent like Capi? How would you strategize this? And is PTEN loss the only thing you're going to use to make this decision? Because Rana needs some other signals, and I think many of us do as well.
Sure, and actually I fully agree with what Rana said. Well, number one, there are good reason to believe that these patients with PTEN loss may actually benefit from docetaxel chemotherapy. Mm-hmm. Retrospective data, but coming from prospective trial, still need confirmation. But actually, outside the trial, and if capivasertib is not available, if I know that the patient has a PTEN loss, like she did, I would go for a triplet and not a doublet. So that's one thing. Second, we know crystal clear that PSA value at 6 to 8 months, say, is a strong prognostic factor. So it's very informative. And what we're targeting classically is below 0.2, but actually probably what we should target is 0. Mm-hmm. And there probably remains still some room between 0 and 0.2 in terms of prognosis. So yes, in a patient who is a poor responder, you'd like to do something. She just explained the ongoing trial in the US adding docetaxel or randomly, but this patient had it already. We actually have a trial in France and in Europe randomizing lutetium PSMA in this particular setting of poor responders, whatever the patient has received before, doublet or triplet. It seems that PSMA is actually expressed often in these poor responders. But whatever the drug and the concept we're randomizing, it's an opportunity for research. That's crystal clear. Unfortunately, we did not start earlier. I think that's part of my regret now, because we know that for a long time. It's also because now we have the weapons available to test those strategies. Yeah. So for coming back to Rena's patients, I think she does a perfect job. She did her best with the available treatments, providing a triplet, and now she's anxious about a progression. She's monitoring very closely his patients so that she may be able to intervene as soon as possible when eventually it will progress, which will likely, unfortunately, happen sooner than later.
I think many of us have those patients that we're just anxious about. You're waiting for the shoe to drop. Now, the other thing, and we'll end with her session on, or question on, well, we do a lot of things in the CRPC state as well as CSPC, not using the right terminology, Dan, many apologies. But the big question is, Dan, if you had this agent, would you throw it in an MCRPC setting and PTEN loss?
You know, it's a great question. You did see that there is, data from a similar agent showing activity in that setting. So I wouldn't say like there's no evidence to do that. It's not level 1 evidence for capivasertib. Our preference is to use it early because I think that's where the biology is more likely dependent on strictly the AKT pathway versus in castrate-resistant disease there are going to be other alterations and whatnot. Yep. That all said, the old adage, better late than never. I mean, in somebody like this, if there, isn't clear small cell carcinoma, if it's this AR variant, if there's this, high loss of PTEN, and we've used other life-prolonging agents already in that population, it's not unreasonable to consider this. Yeah. But, I would probably treat, once they get into the castrate-resistant setting, with more of the proven life-extending therapies like lutetium, 177, or docetaxel chemotherapy, cabazitaxel chemotherapy, before using this kind of off that label. So, to me, the real compelling thing is to use this early, right? The other agents are proven to benefit throughout, even in this castrate-resistant setting. This is really identified to be beneficial specifically in metastatic hormone-sensitive. So when I see loss of PTEN there, my goal is to use it because I want to use everything and I can't really use this later into the same level of evidence that using it earlier, has.
Subsequent to the recording of this program, the FDA approved capivasertib in combination with abiraterone and prednisone for adults with metastatic androgen pathway modulator naive or sensitive prostate cancer that is PTEN deficient as detected by an FDA-authorized test. Please check out the official prescribing information for more. This concludes our program. Special thanks to our faculty and to our case presenters, and thank you for tuning in. This is Dr. Neil Love for A Second Opinion. Clinical investigators provide perspectives on the role of AKT inhibition in the management of prostate cancer.